Welcome to this crystal arthritis review for the third medical licensing exam, brought to you by Roadmap to Residency. Today, we are focusing on gout and pseudogout, and specifically on how the board questions on these topics are written and how to attack them. We are not going to reteach every detail of crystal disease. Instead, we will show you the high-yield question patterns, the traps the writers plant, and the test-taking moves that get you to the right answer quickly. Keep your question bank and a trusted review resource open beside this video, because these patterns stick best when you practice them on real questions. Let us begin. Here is our plan for today. First, we will work on acute gout flare stems and how to choose the correct first-line treatment quickly. Second, we will tackle the timing of urate-lowering therapy, which is one of the most common traps the writers set on this topic. Third, we will cover how to recognize pseudogout and how to answer the diet and lifestyle counseling questions that show up again and again. Along the way, we will walk through practice questions together and explain exactly why each answer choice is right or wrong. This video assumes you already have baseline knowledge from your review resources. We are here to sharpen how you take the test. Our first strategy is to read the joint fluid and the clinical setting before anything else. Joint fluid analysis is the answer to most diagnostic questions on this topic. So learn the two crystal patterns cold. Needle-shaped crystals that are negatively birefringent mean gout. Rhomboid-shaped crystals that are positively birefringent mean pseudogout. The moment a stem gives you crystal shape or birefringence, it has basically handed you the diagnosis. Next, anchor on whether this is an acute flare or a patient between attacks. A hot, acutely painful joint needs treatment that calms inflammation right now. A patient seen between attacks is where prevention and urate-lowering questions live. Sorting acute from chronic first keeps you from confusing flare treatment with long-term therapy, which is exactly the mistake the writers hope you will make. Strategy 2 is treating the acute gout flare, and this is one of the highest yield question types on the topic. First, know that 3 first-line options dominate the answer choices: a non-steroidal anti-inflammatory drug, colchicine, and corticosteroids. Here is the key insight. Any of the 3 can be correct, so the question is never really which drug treats gout. It is which drug fits this particular patient. Second, let the comorbidities choose for you. If the stem mentions kidney disease, heart failure, or a bleeding ulcer, the non-steroidal drug becomes the wrong answer, and a steroid becomes attractive. If only one joint is involved and the patient cannot take those medicines, injecting a steroid directly into that joint is often the elegant intended answer. Train yourself to scan the stem for the comorbidity clue, because that clue is doing the work of selecting the answer for you. Strategy 3 is the timing of urate-lowering therapy, and this is where the writers set some of their favorite traps. First, do not start urate-lowering therapy during an active flare. A very common distractor offers you a urate-lowering drug right in the middle of an attack, but starting it then can actually prolong or worsen the attack. During an acute flare, the answer is to treat the inflammation, not to begin long-term therapy that same day. Second, know who actually needs long-term therapy. It is for patients with recurring attacks, deposits of crystals under the skin, kidney stones from urate, or joint damage, not usually a single first attack in an otherwise well person. Third, and this catches many people, if a patient is already taking urate-lowering therapy when a flare hits, you continue it and treat the flare. You never stop it. And when you do start therapy between attacks, the intended answer usually pairs it with flare prevention coverage during the first months. The theme is simple. Do not start it mid-flare, and do not interrupt it mid-flare. Let us work through our first practice question, and this one is built to test acute gout flare treatment. A 55-year-old man comes to the clinic with sudden severe pain, redness, and swelling at the base of his right big toe that started overnight. The important background detail is that he has long-standing kidney disease. His joint fluid shows needle-shaped, negatively birefringent crystals and no organisms, which confirms gout and rules out infection. The question asks for the most appropriate next step. Notice the crystals gave you the diagnosis, and notice the kidney disease, because that comorbidity should be steering your choice. Read the 4 options carefully and pick your answer, then we will reason through each one together on the next slide. Let us break this down step by step. Step 1. Spot the pattern. Needle-shaped, negatively birefringent crystals with no organisms confirm an acute gout flare and rule out a joint infection. So this is a treat the flare question. And the detail that should be flashing at you is the long-standing kidney disease, because it changes which flare drug is safe. Step 2. Apply the rule. In an acute flare, you treat the inflammation, and because kidney disease makes a non-steroidal drug a poor choice, a corticosteroid becomes the safer first-line option. So, the answer is to give an oral corticosteroid course. Step 3. Eliminate the wrong answers. The high-dose non-steroidal drug is risky in a patient with kidney disease, so that is out. Starting allopurinol today is the classic timing trap, because beginning urate-lowering therapy during a flare can prolong or worsen it, and simply rechecking the uric acid in a month leaves a severely painful flare untreated, which is unacceptable. The correct answer is the oral corticosteroid. Notice how the comorbidity in the stem selected the drug for you. Here is our second practice question, and it is all about the timing of urate-lowering therapy. A 58-year-old man is seen in clinic 6 weeks after his third gout flare this year. Right now, he is completely pain-free, his joint exam is normal, and his kidney function is normal. He is frustrated by how often the attacks keep coming back, and he wants to prevent them. The question asks for the most appropriate next step. 2 details matter here. He has recurring attacks, which is a real indication for long-term therapy, and he is currently between attacks, not in a flare, which is exactly when you are allowed to start it. Pick your answer, and we will reason through every option on the next slide. Let us work through this answer. First, confirm the indication and the timing. Recurring attacks, and here he has had 3 this year, are a clear reason to start long-term, urate-lowering therapy. And just as importantly, he is currently between attacks and pain-free, which is precisely the safe window to begin it. So, both the indication and the timing point in the same direction. Now, why does this answer win? You start allopurinol now, and you pair it with short-term flare prevention coverage, because simply lowering the urate can itself briefly trigger a flare in the early weeks. That is the complete, intended answer. Let us clear the distractors. Starting it only during his next acute attack is the timing trap, because you do not begin urate-lowering therapy in the middle of a flare. Prescribing nothing and just advising him to avoid red meat will not control attacks this frequent, since diet alone is not enough here. And injecting a joint that is currently pain-free treats a problem that is not present. The correct answer is to start allopurinol now, with flare prevention coverage. Now let us talk about recognizing and managing pseudogout, because the board writers count on people confusing it with gout. First, learn the pseudogout fingerprint. Think of it when an older patient presents with an acutely swollen knee or wrist, when the joint fluid shows rhomboid-shaped, positively birefringent crystals, and when an image shows calcium lining the cartilage of the joint. That calcification of the cartilage on imaging is the detail the writers love to bury in the stem, and spotting it locks in the diagnosis. Second, treat the flare, then look deeper. Acute pseudogout is treated much like a gout flare, using a non-steroidal drug, colchicine, or a corticosteroid, and a steroid injection is a great option when a single large joint like the knee is involved. Notice there is no urate-lowering therapy in pseudogout, so any answer offering allopurinol here is a trap. And when pseudogout is new or keeps recurring, the intended answer often includes looking for an underlying metabolic condition driving it. Treat the joint, then investigate the cause. Here is our third practice question, and it targets diet and lifestyle counseling, which shows up constantly on this topic. A 50-year-old man with recurrent gout comes back to clinic between attacks for counseling. He drinks several beers most evenings, eats large amounts of red meat and shellfish, and has gained weight over the past year, and his attacks are getting more frequent. He asks which lifestyle changes will help the most. The question wants the most appropriate advice. Think about which of his habits are the well-established drivers of gout, and be ready for distractors that sound disciplined but are actually extreme or simply false. Choose your answer, and we will reason through every option on the next slide. Let us break down this answer. First, target the real drivers. The habits that are well established as modifiable causes of gout attacks are alcohol and beer in particular, along with red meat and shellfish, plus excess body weight. So advising him to cut back on alcohol, especially beer, and to reduce red meat and shellfish targets exactly those drivers, and it is the correct, evidence-based counseling. That is our answer. Now reject the extreme distractors. A strict water fast is not only unsafe, it can actually provoke a gout flare, so that is wrong. Telling him to avoid all dairy and all vegetables is also wrong, because low-fat dairy may actually help lower risk, and most vegetables are perfectly fine, even some that contain purines. And claiming that diet does not matter at all is simply false, since lifestyle change genuinely reduces attacks alongside medication. The correct answer is to cut back alcohol, especially beer, and to reduce red meat and shellfish. Notice how the sensible, moderate choice beat the dramatic ones. Here is the single most useful pearl for crystal arthritis questions, and it ties everything together. Before you pick an answer, decide which world the question lives in. Are you in the acute flare, or are you between attacks? In the flare, when the joint is hot and painful, the answer is simply to calm the inflammation with a non-steroidal drug, colchicine, or a corticosteroid, chosen to fit the patient. You do not start urate-lowering therapy during a flare, and if the patient is already taking it, you continue it, rather than stop it. Between attacks is a completely different world, where prevention questions open up. That is when you start urate-lowering therapy for someone with recurring attacks, crystal deposits, urate stones, or joint damage, and you pair that start with short-term flare prevention coverage. It is also where diet and lifestyle counseling belongs. Almost every trap on this topic comes from mixing these two worlds, so train yourself to ask, flare or prevention, before you commit to an answer. That one question will save you points. That wraps up our review of gout and pseudogout question strategy. Remember the core moves we covered. Let the joint fluid and the crystal shape hand you the diagnosis. In an acute flare, calm the inflammation with a non-steroidal drug, colchicine or a corticosteroid, and let the patient's other conditions choose which one. Do not start urate-lowering therapy during a flare, and never stop it during a flare if the patient is already on it. Start it between attacks for recurring disease, deposits, stones, or joint damage, and pair the start with flare prevention coverage. Treat pseudogout like a flare. Remember there is no urate-lowering step, and look for an underlying cause. And for lifestyle counseling, steer toward moderating alcohol, especially beer, along with red meat and shellfish. The best way to lock all of this in is to drill questions under timed conditions and read every explanation. Visit roadmaptoresidency.com for expert tutors and residency advisors who can help you build a personalized study plan. If you found this video helpful, please like and subscribe so you do not miss our next board review session. Good luck on your exam, and we will see you in the next video.